Hey everybody, I'm just going to do a quick test review. I know y'all are all doing clinicals at different times, so it's going to be almost impossible to get all of y'all together before the test on Friday, so I wanted to go ahead and do this real quick and just record it and post it on Georgia View for you. So you have the neurosensory test on Friday. I wondered why y'all asked me if it was the 3rd or the 10th until I got in there and was looking for it and realized that I put the 3rd on it. Sorry about that. Didn't mean to scare you to death. But this is not the hardest of tests. It's just one that has a lot of different like skill tests. So things that unfortunately y'all haven't been able to practice, but we'll talk a little bit about them. You definitely want to know your cranial nerves, know the names of them, what number they are, and what they test. There's little mnemonics all over the place, and I would tell you the one I had to use to memorize it, but then they've changed the name of them, so my mnemonic wouldn't work for you anymore. My students last semester, or the fall of 2019, came up with all kinds of mnemonics for themselves that help them, so if that's what you need to do, do it. Know stuff about seizures. So if you walk into a room and a patient's having a grand mal, what we used to call grand mal, now tonic-clonic seizure, you want, number one, to make sure that you pad the bed rails so that if they're flailing around, they don't end up hitting their heads on the bed rail. You want to make sure that you turn them on their sides to keep them from vomiting and then aspirating on that. But with everything we've learned these 2 semesters, the most important thing is to maintain airway, whatever that takes. Big things you do not want to do. You do not want to stick anything in their mouths. The old way of doing it was to take a tongue depressor and stick in their mouths. Now we're learning, or I'm not going to say now, it's been at least 15 years ago, we figured out that breaks teeth. So don't stick anything in their mouths. If they do have saliva coming out, you want to just hold that yonker up to their mouths, but don't force it into their mouths, because that again can break teeth. If a patient is recovering from a tonic-clonic seizure, know that they're going to go into that state where they're going to sleep for like 30, 45 minutes or maybe even more. I mean, think about how many muscle movements that person has gone through. They've ran a marathon in a matter of just however many minutes that seizure's lasted, so they're going to be tired. So they're just going to sleep. You want to do an assessment after the point of the seizure. You want to listen to them and see what their respirations sound like. If they don't sound normal for that patient, you need to do something about it. Know what part of the brain controls what. What your frontal lobe does, occipital lobe, all those different parts of the brain. So we talked about we talked about cranial nerves just a second ago. Know your neurotransmitters that are in the book that they talk about. So you got neurotransmitters for your sympathetic nervous system when that one's kicked in, when you're in fight or flight and you're scared as crap over something. And you have for your parasympathetic where everything's calm inside. Just know those neurotransmitters. So lumbar punctures. I know we've talked about this a little bit, but for lumbar puncture, I don't know if any of you have ever assisted a patient with or a nurse with a lumbar puncture or a doctor with a lumbar puncture. You are going to get that patient in a side-lying position, and they are going, sorry, let me charge my phone. They need to be in kind of a fetal position. So you're going to get them to draw their knees up close to their chest. And I think there's a picture in the book, and there's a PowerPoint that shows, but you just want to assist those patients. With an adult that's fully functional, that's mentally stable, not having altered mental status, that's not hard. If you're dealing with a baby, a child, or someone who is combative, for whatever reason, it makes it a little bit more difficult. After the procedure, you want them laying flat for at least 6 hours. and that will help prevent that lumbar puncture headache. If they come up, very often they'll have a headache that they will describe to you as the worst pain of their life. Know your different postures, your decerebrate and decorticate postures that are in your book. Know about whenever you're doing your pupil check. Remember what it means if for example, when light is shined into one eye, both pupils constrict. That's consensual. Just know that. Just know those. Memorize your Glasgow Coma score. So if I say a patient is opening eyes to voice, talking normally, and withdrawals from pain, or whatever, know what that means. Just memorize those. That is a test that you will use a lot whenever you become a nurse, especially if you're working in a hospital. We do GCS on everybody, and very often we do GCS on patients that don't need GCS done on them. So just know those scores. Know your meningitis and your signs and symptoms of meningitis, and just know what it's going to be like. So know your signs if a patient has meningitis and it's improving, what their signs and symptoms are going to be. Know your headaches, what's causing your migraine headaches, what causes your tension headaches. Big thing with headaches is always keep a headache diary, because you want to know what the trigger is for that headache. Something that I don't know if the book really discusses, a lot of people believe that if you have seizures, or if a patient has seizures, they can't drive. They can't drive if they have active seizures. If they're medicated and they haven't had a seizure for a certain amount of time, they will be able to drive. I think in Georgia it's 6 months, but don't quote me on it. Don't go to the DMV and quote me on it. Know about your bleeds in the brain, so your epidural bleeds. Know about head injuries. So I'll just give you a question here. Patient with a head injury has a widening pulse pressure. What do you need to do for that patient? You need to raise the head of the bed and notify the doctor. Know about spinal shock, and remember that's what can happen after a spinal injury. If they've, been diving and ended up breaking their spine, their neck, whatever, that is where they can have some serious injury, and that body can actually shut down. So know more about spinal shock. Know about the different parts of the spinal column. So if I injure L3 and L4, what's going to be possibly paralyzed? And it always goes by whatever from that point down. So if I injure, L3 and L4, everything down from there is going to be injured, which is going to be pelvis and legs. So that's what I'm probably going to lose function of. Probably still be able to use my arms. Respiratories, cardiac, all that's still going to work. It's just going to be my legs. But think about if you break at C3, C4. You're going to lose arms, leg. That's where you're going to end up with someone who's completely paralyzed. Know your quadriplegia, paraplegia, all those words that are in the book. Know what Parkinson's signs and symptoms are. And just know what you should do to treat those patients. Know medications that are common. Know what nursing interventions, non-medical nursing interventions can be done. So if a patient, and we talked about this a little bit with the, if you're going for the pituitary through the brain, through the nose into the brain, If you have any kind of brain surgery and you notice, so you pull the gauze away or the bandage or whatever, and there's a pink spot, so you know that's probably blood, but it has a yellow ring around it or inside of it, either way, it's probably 99% sure it's going to be cerebral spinal fluid. So you need to notify, if you're LPN, you need to notify the RN. If you're RN, you need to notify the doctor, because you got to do something quick. Loss of CSF can be very, very detrimental. Know what a TIA is, so a transient ischemic attack, versus a CVA. TIA are those short strokes that can last anywhere from a matter of minutes up to hours. So it's just when the brain is deprived from oxygen for a short amount of time. But remember, TIA is a precursor for CVA. If a patient's had a TIA, they are at a much higher risk for having a CVA. Know your aphasias, your dysphagia that it talks about in the chapter. Know your medications. So know your warfarin, your aspirin, all your blood thinners. And I don't mean those odd ones. I mean like your Plavix, Xarelto is a common now, Brilinta. Just know about them. I think there's a table in your book that talks about them. But know the difference in them. Know the different classifications between aspirin and warfarin. Know what a cerebral angiogram does. It detects vascular lesions in the brain. So if a patient is showing possible signs of a stroke, it can go in and find that problem. So rehab after strokes are very common. So you have a patient come in, they're past their point of being able to TPA them. So they have weakness in some part of their bodies. Very often they'll go to rehab after release from the hospital. The goal of rehab is to maximize what abilities they have. So let's say I'm right-handed and it affects the right arm and right hand. I can no longer use my right arm and right hand. Rehab will help me learn how to use just my left hand. Can help strengthen that right hand to possibly someday get better function with it, but they're going to concentrate on teaching me to use what I already have. Biggest thing when you have a patient come in, if you're working ER, they come in with whatever symptoms, memory loss, one-sided weakness. Sorry, the power just went out in this place. Hang on. Sorry, I sit still too long in my office and it made the power go out. So one-sided weakness, tingling in the hands, anything that makes you think stroke. The biggest thing you need to know is when those symptoms started. So because you're automatically thinking TPA. So if it's 30 minutes ago or 90 minutes ago, woke up and they were that way, whatever, you need to know when it started. Know your foods to take off a tray to prevent aspiration. So your biggest ones are going to be liquid. You want to take any kind of coffee, water, juice, cola, whatever off of the tray, because that's a higher risk of aspiration. No, we talked about the 4 FOUR assessment. That is, I don't remember exactly where it's in the book, but it's very common, it's used right along with the Glasgow Coma Score, especially if a patient can't talk, and that's normal for them. They're unable to talk for whatever reason. Know about what that tests. Know about myasthenia gravis and its signs and symptoms. Know what your Weber test is, your whisper test. Things that you can meet a person and suspect that they have hearing loss. If that person is cupping their ear and getting closer to you to understand you, probably hearing loss. If that person is speaking in a really loud tone of voice and they're, in church or at a funeral or whatever where we should be quiet, probably hearing loss. Anything where they're just acting abnormal for being able to have a normal conversation. Know about your visual tests, so your visual field, your six fields of vision, I think is how it's called. Remember that to measure intraocular pressure, which is the pressure in the eye, you're going to use a tonometer. Letters, I think you would have learned back in fundamentals, but just to jog your memory, PERLA, PERRLA, stands for pupils equal, round, reactive to light, and accommodation. Remember, if possible, if you're examining pupils, you want to have the patient lying down in a slightly darkened room. You don't want a completely darkened room because you're not going to be able to see, but just a slightly darkened room. That's not very often possible, but that's ideal. Know the different visions. So if I have 20/20 vision, I have perfect vision. And that means that I can see at 20 feet what somebody else can see, what someone else with normal vision can see at 20 feet. But if I have 20/50 vision, that means I have to be at 20 feet what they can see from 250 feet, which is a big difference. Remember, if you're administering eye drops, and most people don't do this right, but just know this for the book, especially if you're doing steroid drops and you're doing a strong steroid drop, you want to have the person lying down and you want to hold pressure right here on this lacrimal gland for 1 minute. That's the big key, is 1 minute, because you don't want those steroids to go systemic throughout the body. Remember that, as the old saying goes, this is what my mama used to tell me, don't stick anything in your ear smaller than your elbow. And yes, I know you can't stick your elbow in your ear. That's the point of the story. That cerumen protects your ear. And sticking a Q-tip down in there, number one, you can puncture your eardrum. Number two, you can end up causing an impaction. So you push that cerumen back down in there and then you end up with impacted eardrum. So then that's where you have to use the syringe and clean it out. So tell people that all they should be doing is cleaning the outside of the ear. They can clean right in here some, but do not stick anything down in that ear. Hearing aids, know what kind of hearing loss that it helps. Know your far-sighted versus nearsighted, and know their scientific names and how it's treated. So what kind of lenses are needed to treat farsighted, to treat nearsighted? Remember that conjunctivitis or pink eye is very easily contagious, and just figure out what you need to do to prevent it. Know about your signs and symptoms of your two types of glaucoma. So we talked earlier about ear irrigation. So if you got cerumen stuck down in there, you do not want to do ear irrigation on anyone who's had a punctured eardrum in the past. Because you can get liquid down in there, and that's not a good thing. That eardrum is there to keep liquid out. Same thing with, if you're going to look at the eardrum of a patient, you want to ask them if they've ever had a punctured eardrum. I have a friend who had punctured her eardrum when she was a kid, and then a doctor went to look at her eardrum again, and this was years and years later. We're talking 20 plus years later, and he ended up puncturing that eardrum again. So definitely increased her chances of being deaf. I don't think she had any problems with it, but it does increase your risk. Know about vertigo, know about Meniere's disease. And Meniere's disease is the one and only time you will ever be told to increase your sodium level. Important thing to remember. We want to lower it with diabetes, with with high blood pressure, with heart disease, all that stuff. With Meniere's disease, you want to raise it. Just like I told you to know about your nearsighted and farsighted, know astigmatism. Know about your Romberg and how to keep your patient safe during that. Know those words for hearing loss as you age and vision loss as you age. Know both those words. Most common ear infection is going to be your middle ear. Remember, your outer ear is usually swimmer's ear, where you've gotten wet. Know what to avoid know what to avoid doing to avoid increasing intraocular pressure in the eye. And that's going to be anything that's like it would increase intracranial pressure. Coughing, blowing the nose, bending down, lifting up anything heavy, anything like that. There are, and I talked about this a little bit, the ototoxic drugs. There are certain medications that can lead to deafness. Gentamicin is a big one. A lot of your mycins will. But one that's not thought about a whole lot is Lasix, and we give Lasix like it's candy a lot of times, especially with congestive heart failure, but that can lead to hearing loss. What do you need to teach your patient who's having, who's got an eye patch after surgery? You pretty much want them doing absolutely nothing with their eyes. You don't want them watching TV, because that's gonna make them move that eye. You don't want them exercising that eye. You don't want them thinking about moving the eye that's not patched. Well, I'll exercise that eye. Can you really move one eye without moving the other? It's not possible. So you want them doing absolutely nothing. Pretty much laying still, listening to music. Or sleeping. Know about detached retina and your signs and symptoms of a detached retina. Know about your non-pharmacological treatment for ear pain. Know what macular degeneration is and what it affects and how it's treated. And know your wet versus your dry. And then last thing, what your acute angle closure glaucoma, know what medication to avoid to not give to that type of glaucoma. It's fine for the other type of glaucoma, but you can't do it to acute angle. As always, if y'all think of any questions, I am more than willing to answer. I just wanted to go ahead and do this, like I said, because y'all have clinicals at such odd times that I didn't think I'd be able to get y'all all together. So I just wanted to do a test review, but get it to where y'all could all see it and not have to worry about one of you missing it. If you have questions, call me, text me. I will be available tomorrow. I'm just going to go hang out with my niece who's in foster care, and so I can't bring her to my house, so I'm just going to go hang out with her. I'll be available Friday, and I will open the test up Friday morning and then Sunday morning. In case anybody missed it, I will be here with Aniston and Brandy on Friday at like 2:30 to go ahead and do their one or two or whatever they decide of their ATI tests. If anybody else needs to take advantage of that time, great, come on. We are also doing them on Monday at 10 a.m. We're doing them Tuesday, I think we decided at 6:30 p.m. And then y'all are going to do it with Jennifer, I think at 10 a.m. on Thursday. Don't quote me on that. Check with your class to make sure, because I wasn't in on the Thursday. So that gives you 4 opportunities. If you have to take all 3 tests together, Jennifer said that is not ideal. It's going to be 400 questions. But if that's what you got to do, you got to do it. Remember that the mental health and the Med-Surg do count towards your grade. I've heard the comprehensive doesn't, but that comprehensive is great because it's going to tell you where you stand with NCLEX, and that's something real important to know, so you know what to concentrate on studying before you take the NCLEX. If you have any other questions, need anything at all from me, please text, call, email, whatever you need to do, and I'll get back to you as soon as I can. But otherwise, I will talk to y'all later. Bye.